Okay, thank you, everyone. Hello, everyone. My name is Marwa, as we've said earlier. I'm a fourth-year PhD student in the Network for Nonprofit and Social Impact Lab, representing for our group. With us, we also have Dr. Michelle Shumate and Chae-Win Jang. The title of our paper is Beyond Service Volume, Validating the Trajectories of Care Metric for Long-Term Veteran Referral Success. We're going to thank...
Go to the next.
Okay.
You're good.
All right, thank you so much. All right, so this study was made possible by a team of amazing people in our lab. We have already introduced the people on this slide. We also have an undergraduate team, Tatum, Maya, and Lucia, who have also contributed to this work. Also an integral part of our research, our partner network representatives, Mike Hutchings, John Green, and Brian Escobedo from Combined Arms, as well as Gilly and Zachary. The data used in our analysis come from two networks, America Serves and Combined Arms. We've all just heard of the America Serves model, and unlike America Serves Coordination Center approach, Combined Arms does not have a center coordination institution. Clients can easily request services and guide themselves to organizations via the mobile app or the desktop platform. And if an organization cannot meet those clients' needs, they will refer clients to other organizations that can provide those services for them. Combined Arms uses the technology provider Salesforce to support and collect client information, WHO-5 survey results, and case records. This paper describes referral networks as systems of relationships among organizations that allow them to direct people to appropriate services that are not available at their own facility. Referral networks serve as a bridge between service providers and clients, pivotal in ensuring effective and efficient care. Integrated care coordination describes a network of public and nonprofit organizations offering clients comprehensive and integrated social and healthcare services. Like our partner networks, most successful networks deploy technology systems that support seamless referrals and individuals responsible for effectively running the network. Using these technology systems, networks and researchers have existing measures and evaluations of successful case management. You've already heard about several process metrics from Zach. In addition to those, we include case volume, which is just the number of people who are served, and the surveys-based measures of satisfaction or well-being. Prior network performance metrics operate at the service level and measure networks' process performance without considering the accumulated outcomes of interacting with service providers. Surveys capture client well-being at one point in time, and they're subject to high rates of missing data as a result. In contrast, we use systems data on service requests to derive the TOC metric, which measures client-level success. We define positive individual-level performance as the longitudinal improvement of clients' well-being across service episodes. Longitudinal improvement of client well-being across service episodes would mean that clients are successfully addressing their needs, which would have a positive impact on their well-being and overall quality of life. Traditionally, networks have been evaluated on the demand and supply of their services. A network is good if it can refer people to service providers that give a wide range of support for people's needs. But do these services actually improve client well-being? Very few consider an individual level understanding of network effectiveness, which is client outcomes. We believe that requests from a client signal a client's needs more than what they've already received, and the percentage of cases that were successfully resolved. For example, a client might continue to request a service for the same need or returns with additional, more pressing needs because of that initial need. This would indicate that their needs are not being met and that their well-being might be worsening as a result of pressing unmet needs that continue to accumulate. An example of a successful improvement for a client would be if there's a shift in the needs that they request, such as first requesting a major need, such as housing, and then later asking for a volunteer program. Their needs appear to become less acute, contributing to a better well-being over time. We assert that it's important to understand performance at the client level, because this allows networks to better gauge the impact of their programs and services based on how their clients' needs would change over time throughout their system. The trajectories of care metric relies on an insight from Maslow's hierarchy of needs. Social needs are not equally acute. Instead, an individual's needs can be ranked from most acute to least acute. using this hierarchy of needs as a reference, we argue that well-being might be associated with a higher level of need, and that one of the foundations of the trajectories of care metric is that a positive trajectory would see needs become less acute over time, and a negative trajectory would see needs become more acute. At the client level, we want to measure client improvement over time to make recommendations. This would allow us to recommend a particular set of providers and services for clients based on whether they provide these services and then in turn resulted in better trajectories of care for similar clients in the past. One way to think about our goal is to consider what other recommender systems that you might be more familiar with. Netflix uses data on viewing habits to predict what other kinds of shows will keep you tuned into their platform. They make recommendations with increased viewing as a success metric, so the more you keep watching, the more successful it is. Amazon makes product recommendations based on success metrics of purchasing. Based on what other people have already bought, it will recommend what you should buy. Similarly, we aim to make recommendations. However, we want to make recommendations based on a set of recommendations that lead to greater client well-being. So we need that data on which previous referrals have led to decreased social needs over time. These are the 4 guiding questions for this paper. However, for the sake of time, I'll just talk about research question number 1 and research question number 4. And anybody who is interested, we can absolutely share more details with our whole paper. Research question number 1 asks, how do social care providers rate the acuity of social care needs? The results of our first research question are reported more fully in this white paper, and we have a QR code here that you can scan to read more about. Our team adopted a sequential mixed methods design to give a high-level overview, combining both qualitative interviews and organizational surveys. We began with interviews of 21 Dallas-Fort Worth intake providers, and the purpose of the interviews was to gain a better understanding of how providers would rank services and resources in their network. At the beginning of the interview, we covered the intake providers' services and their referrals, and they were asked about the combination of typically co-occurring needs and services, and the client's progression of need, order of need, and the typical sequence that they often see referrals that clients experience. Intake providers gave insight into evaluating a client's readiness to progress from one stage of service utilization to the next. Intake providers were then asked to rank service groups on this mural application, and this is an online collaborative whiteboard where we can see each other's screens. The respondents ranked 122 services, and based on the ranking of the service groups, the research team asked follow-up questions regarding the number of categories the interviews created, the different groups that the services were put under, and the features of categories based on their service. So as you can see, they would choose the service that they felt like was lowest priority and then highest priority, and then we just asked whether they purposely grouped them in any certain order. Drawing on the insights from these interviews, we conducted a survey targeting case managers, coordination center employees, and service providers across the America Serves and Combined Arms networks, and we received a total of 130 responses. Based on these surveys, we classified services into 3 types of need. Basic needs, such as clothing and household goods, housing and shelter, physical health, and then stressors, such as community engagement, legal assistance, and home repair, and then non-essentials, which were entrepreneurship and sports and recreation. Services were then put into these categories based on those survey responses. We worked iteratively with intake staff to identify additional factors other than the acuteness of need that would influence how they viewed a client's trajectory of care. We identified 3 additional factors. Number 1 being whether the client requested the same service in consecutive episodes. This often signals failures in meeting clients' needs, so it should be punished when calculating trajectories. Number 2 was a decrease in the volume of services requested over time. This would suggest improving well-being because the client is presenting less and less needs over time. And number 3, since housing was seen as the most basic need, requesting housing assistance often indicates a client's worsening well-being. This is the final equation that we use to calculate the trajectories of care metric. Knowing the characteristics of trajectories of care, we validated the metric against 3 existing rating standards. Tests of validity are designed to demonstrate that a metric is measuring exactly what it says it's measuring and not what it's not supposed to be measuring. Concurrent validity is a test to see if the measure aligns with other established measures that should be related to the concept we're looking at. The World Health Organization 5 Wellbeing Index, which is the WHO-5 score that I keep mentioning, is a questionnaire with 5 questions that helps assess people's subjective quality of life, and with a higher total score indicating better well-being. Research has shown that the WHO-5 has adequate validity in measuring clinical trial outcomes for clients. In our test for concurrent validity, using the WHO-5 scores from combined arms clients, we found that clients' WHO-5 scores are significantly related to the lowest need of their recent service episodes. We saw that compared to clients whose lowest need was a stressor or a non-essential need, clients whose lowest need was a basic need had a lower WHO-5 score in general, so that basic need being housing is a possibility. For expert validity, we tested whether experts would rate clients' trajectories of care based on their case management data, similar to our metric. Expert validity was assessed by comparing the trajectories of care with independent expert ratings of 500 different case records. We found that the trajectories of care were moderately related to expert ratings. Discriminant validity is designed to test where a measure is different from one that we didn't expect to be related. We compared trajectories of care to AmericaServe's client average case resolution rates. And we found that there's no significant relationship between our trajectories of care and client success rate, which supports the finding that clients' trajectories of care are different from the delivery of services. And through all these evaluations, we do find that the trajectories of care metric demonstrates strong validity across the board. Research question number 4 is, what factors influence these trajectories of care? Factors that we assumed might affect the client's trajectories include demographic factors and dynamic case factors. Demographic case factors are clients' gender, age, service era, race, ethnicity, education level, housing status, income level, pay grade, and whether or not they have children. While dynamic case factors include having requests for different services in the first service episode and the complexity of that first service episode. The regression also reveals that multiple demographic factors are influencing trajectories of care. More specifically, those factors being a female, serving during or after the Vietnam War, being an African American, and owning a residence have shown to have negative impacts on trajectories. Although age and income level are statistically significant, they made no practical difference to our clients' trajectories. Upon running regressions, we did find that there was a tendency for clients to regress towards the mean. That if they requested basic services during the first service episodes, they were more likely to have a positive trajectory over time. But on the other hand, requesting stressors and non-essential services in the first service episode was associated with more negative trajectories. But perhaps most importantly, we found that controlling for service requests, we saw that clients with higher complexity, which would be requesting more types of services in that first service episode, tended to have higher trajectories of care over time. A trajectory of care metric is a powerful tool for making referral decisions. Recognizing and addressing the multifaceted nature of clients' needs strengthens veterans' long-term health and well-being. And since the trajectories of care metric provides a new client-centered approach, networks like AmericaServe's and Combined Arms are better equipped to identify client trends. Rather than focusing on things like volumes of cases or measuring success by its referrals, these networks can holistically understand how clients enter with particular needs and then navigate throughout their systems as those needs change. Our paper introduces the trajectories of care metric as a cost-effective approach for the referral networks to evaluate client outcomes over time. And this metric underscores the importance of not just closing a case and calling it good, but navigating the underlying patterns that perpetuate cycles of unmet needs and lead to a more nuanced understanding of trajectories of care for the people that live in our communities. Thank you. We also have our Impact Insights monthly newsletter on a QR code for people to scan to.